My name is Doris Hansen. Today we are in Orlando, Florida for ASH 2025. Today I presented on incidence and management of non-ICANS neurologic toxicities following standard of care cilta-cabtagene autoleucel. Cilta-cel has shown impressive efficacy with a median overall survival of 5 years, with 33% of the patients being alive and treatment-free at 5 years. However, it is associated with non-ICANS neurotoxicities. About 6% of patients in CARTITUDE-1 develop Parkinson's as opposed to 1% in CARTITUDE-4, and 3% cranial nerve palsies in CARTITUDE-1 and 9% cranial nerve palsies in CARTITUDE-4. So the goal of our study was really to identify the incidence and management of these non-ICANS neurotoxicities at different time periods in terms of lines of therapy, and importantly we used loopback analytics as our data source. Here we saw about 73 patients who were treated with cilta-cel in 2 to 4 prior lines of therapy, and about 98 in those who had 5 or more prior lines of therapy. We essentially saw that the rate of cranial nerve palsies in the 2 to 4 prior lines of therapy was about 5.5%. There was no Parkinsonism or Guillain-Barré, but in those who had 5 or more prior lines of therapy, cranial nerve palsies were about 3%. One patient had Parkinsonism and one Guillain-Barré. Importantly, the absolute lymphocyte count was obtained prior to lymphodepletion and peak value as well. And we saw that those who had cranial nerve palsies had a median peak ALC of about 8,000, Guillain-Barré of about 9,000, and Parkinsonism of about 15,000. In terms of management, we saw that cranial nerve palsies generally were managed with steroids and IVIG, and commonly improved or resolved with that treatment. For Parkinsonism, cyclophosphamide was given, and for Guillain-Barré, plasma exchange as well as IVIG were given. So in summary, our study shows that cilta-cel does have non-ICANS neurologic toxicities. Generally, Parkinsonism rates are lower in earlier lines, but cranial nerve palsies do occur in 3% or more of the patients. And the most important is we need to identify a biomarker or other multiple biomarkers that help predict to mitigate this toxicity, and absolute lymphocyte count could be helpful to identify prophylactic strategies for our patients. Thank you very much.